Good evening. Tonight we're going to cover medical emergencies, a number of different topics. Very important to an EMT and the sort of thing that you'll be doing. So ultimental status, seizures, allergies, poisonings, and overdoses. We're going to cover all these topics and understand them on the EMT level. Let's start with ultimental status. All right, this is a topic, this is a concept that we talk about a lot in medicine. All right? What is ultimental status? Well, all it means is the person is not acting their norm. They're not acting the way they usually act. Now, if I walk into a apartment or house and I see this patient sitting here, writing notes with a banana on his table, could I possibly know from that information that he's ultimental status or not?
Even though he's writing the banana. You don't know.
The banana's a dead giveaway.
The banana's a dead giveaway, right? How? Right? Because if he'd had Izzy's on the table, then we'd know he was 100% fine.
Weird, but it's not ultimental.
Right. So the answer is we don't know. We don't know. So how does this whole concept of ultimental status happen? How does it evolve? How does it? People call up. They call EMS, or whichever agency it is, and they say, Bob is not acting right. Right? And if Bob is not acting right, well, then we may have a situation of Bob being ultimental status. Ultimental status. So we need to, first of all, decide how we're going to figure out, is our patient in a state of ultimental status? Usually, this information will come from a loved one, or from a roommate, or from some significant other who is calling and telling us that Bob just isn't acting right. That's usually how we get that call. Okay, now, reasons for a patient being ultimental status. What has changed? What has happened? So there are many reasons that a patient can be in this state of not acting right, okay? Ultimental status just goes from answering a couple of questions wrong, asking for strange things, thinking it's wrong time of day, sort of AFPU stuff where they're getting the questions wrong, goes all the way down to being in a coma. All that is in the same idea, concept of ultimental status. So, some of these we're really going to get into and talk about quite deep. I want to explain something. The most common form of ultimental status that we see in EMS has to do with this word here, hypoglycemia. I'm going to explain what that is and how that affects us a little later on tonight. So, the most common form of ultimental status is hypoglycemia. However, it is not the only form. And this is something I want you to understand. And always keep an open mind. So on one hand, you walk in, you see Bob, he's acting weird, the family says he's not right. First thing that should go into your head is hypoglycemia, possibly. But then there's a whole bunch of other things that it could be.
Hypoxia.
Right.
Seizure.
So, quick story. I was called to a doctor's office on Eastern Parkway for the patient with ultimental status. Okay? EMTs got there. The doctor's there. The patient is doolally, off their rocker, saying crazy things. An older lady, just out of her mind, okay? What's going on? Okay, EMTs called for medics, needed, figure out what's going on. I walk in, first thing I see is this lady who's obviously not acting right. She's saying crazy stuff. There's a husband there, he tells me, she's never like this. She knows what's going on, she's not ill, she's not sick. She's just out of her mind, right? She's saying all these crazy things. So what's the first thing I decide to think about? Hypoglycemia. I asked the doctor, did you check for hypoglycemia? Doctor says, yeah. And he gave me a number, and it made sense that that lady was not hypoglycemic. So now I go down my list. So I ask, does she have a seizure disorder? No, never had a seizure. Does she take medications for seizures? We'll talk about more about seizure. Okay, maybe she's having a stroke. We do the check for the stroke, something we'll get to later tonight. Doesn't look like she's having a stroke. Had trauma. I'm going down the list.
Is this a...
No, not in any particular order. These are just things that cause altered mental status. Go to head trauma. I asked the husband, did she fall? Did she bang her head? Anything like this in the last 24 hours. Nope, absolutely no head trauma. We rule out poisoning, intoxication, drug abuse. So the only one I'm left with is this, hypoxia. She had no signs of hypoxia, no clinical signs, but I take out my pulse ox, which is built into the monitor. Again, it's a machine, a device that you're able to use now and use. And I put it on her finger. I get a very low reading, very low. Let's say it was in the 60s or 70s, really low. She was not cyanotic, and she was not short of breath. She wasn't showing any of the signs of hypoxia. Guess what? Tell the EMTs, let's go, oxygen, right? We can fix hypoxia with a non-rebreather mask and 15 liters of oxygen. We fixed her. We got her sats up into the 90s, and she started acting completely normal.
That's crazy.
Okay?
We had a patient, we arrived at, she was at 74. And we gave her oxygen, went up to 96 in
Okay.
2 minutes.
And how did her mental status change?
Well, she was actually fine. Mentally, she was fine.
Okay,
at the beginning.
so, okay, so you had a breathing, respiratory, oxygenation problem.
Right.
Here, it wasn't manifesting as any sort of oxygenation or respiratory issues.
What is the correlation between the low pulse ox and the crazy?
No, she was hypoxic.
And the hypoxic
No,
causes...
Yeah, her brain needed more oxygen.
Where did it come from, though?
Okay, so exactly, that's a whole later story about the hospital and one thing or another. I don't want to go into that. I want to keep it, focused. My point is that even though this is a dichotomy, right? Even though most of the time it's going to be hypoglycemia, don't forget that there are many other reasons for a patient being altered mental status at the same time. You all good with that?
Say that one more time?
Even though the most common
Sure.
problem comes along with hypoglycemia, it's not only hypoglycemia. It's
Okay.
just whatever.
Look at that slide.
A few months ago, he collapsed on the table. I once mentioned it, and looking back after learning all this, you can honestly see the early signs of his altered mental status. He was kooky. He was saying weird things. Then he started saying the room is dark and I can't hear, and then just collapsed. And I saw the guys, school came, they were saying, oh, he's diabetic, hypoglycemia. He's like, he's not, it's something else, and they were insisting that this is the issue.
So here you go. So this is exactly what I'm trying to tell you. I'm okay with you thinking first off that it's hypoglycemia. That's okay. But don't be tunnel visioned and don't ever say that that's the only thing it could be. There are many reasons for AMS. These are just a few that I'm putting on the board here.
Why did you skip a syncope? Or you just...
Because some faints, they syncopise, big deal. We'll talk about that later.
Is fainting?
Yes.
Yeah, we'll talk about it later. All right, let's talk about diabetes, okay? So, real important thing to say about diabetes, which most people don't know and don't understand. Diabetes is not a sugar problem. Okay, I'll say that again. Diabetes is not a sugar problem. Okay? Let's just understand this. Diabetes, the whole disease, is a endocrine problem, and in particular, the pancreas, which produces or needs to produce insulin. We will talk about it. Let's just get some basic understanding of the disease. When I first became an EMT, they did not use these titles, type 1 and type 2. Today, that is the most common way of describing diabetic. So they're either a diabetic type 1 or diabetic type 2. What's the difference? Type 1 is what we used to call IDDM, insulin dependent diabetes mellitus. Okay? So, the way I remember which one's which is because the insulin I is the same here as the I. And type 2 is like an N. If you put a line between the two, you have an N, non-insulin dependent.
Like a gematria, add 3 minus 5.
Right, just add
It might
a
go a little further. You can be off by
one for the word, right?
Yeah.
So, insulin dependent, non-insulin dependent. Let's talk about diabetes for a minute, okay? Diabetes mellitus, the words mean sweet urine, okay? And until not that many years ago, maybe last 100 years or so, doctors in this country were tasting urine, were putting it on their tongue, and tasting to see if it was sweet or savory, okay? Right? Hopefully not sweet and sour.
It's not redundant, sweet urine?
Right. There's non-sweet also. Okay? So I'm told. So, what you need to be aware of, that there are 2 types of diabetics that are out there. There are diabetics who are type 1, and how will we classify them? Type 1 diabetics, they take insulin, and there are diabetics who are type 2, and we'll classify them as non-insulin dependent.
Is there one that's
Okay.
more common?
Let's just say there are type 1 diabetics and type 2 diabetics. And that's it. That's how we're going to distinguish between the two. Okay? There are 2 other types of diabetes. Gestational diabetes is only found in women during pregnancy. I'm not going to go into it. And there is something called diabetes insipidus, which has absolutely nothing to do with sugar whatsoever. And I don't really teach it, I just mention it here so you know that the word diabetes is used in other scenarios as well.
And it's
Okay?
they're all in endocrine.
Yes. What you're gonna deal with, what you're gonna see or have to take care of are gonna be type 1 or type 2 diabetics, and I will get you all the information on the types of emergencies that you may see. For now, just understand these are the 2 types. Clear? Type 1 takes insulin, type 2 does not. Alright, so what is insulin and how does it work? Okay? It's very, very simple. Insulin is produced by the pancreas. Okay? It's actually I left this in the islet of Langerhans. That's a part of the pancreas that actually produces the insulin. You don't need to know that. And how does it work? So here we go. Here's a cell. Here's an insulin receptor. Insulin produced in the pancreas drops in. That opens the glucose channel. And in drops glucose into the cell.
So it's like what?
Glucose is a huge molecule. Glucose is a very big molecule. It cannot diffuse through a semi-permeable membrane, cannot diffuse itself into a cell just like the gases that we've seen and we've spoken about. So it needs these special channels. In order to get the channels open so the glucose can enter,
Where's the glucose coming from?
we'll get to that. Forget the glucose, we're just talking about the insulin now. The insulin needs to get into the insulin receptor, and it's literally like a key. You put the key in, you turn, and it allows glucose into the cell. Alright? Every cell needs glucose.
Where's that receptor? In the pancreas?
In the cell. No.
Every cell.
From the pancreas.
Every cell. The insulin is produced by the pancreas and then shipped off in the blood
Uh-huh.
around the body. Okay?
It gets dropped
So
off by the
normal,
cells.
healthy pancreas produces insulin. Sugar comes from everything you eat. It gets broken down, your food. The sugars then need to go into the cells so that the cells can live and produce
And
energy.
the only way they can get in is
Is by the
assistance of
insulin opening up
allowing
the
them.
channels, yes.
How many times does this occur naturally in a person's body?
Constantly.
Constantly.
Constantly. Okay? So, now we have a better definition of diabetes. Okay? Now we have a better definition of diabetes. Here's the pancreas, right? So it's either an endocrine disorder causing a lack of this hormone insulin, meaning these little yellow things would not be opening the channels, allowing the sugar into the cell, or it can actually use what it's producing, okay? So many people that take insulin shots, what that means is that they are not producing any insulin, okay? They are diabetics, type 1, they don't produce any insulin or so very minute amounts that it's hardly working. They take shots, whether it's the new one that's once a week or a couple times a day, yeah, insulin shots, and that allows glucose from the food and the blood, and we'll talk more about that soon, to get into the cells, and then the cell can do what it needs to with the sugar.
This is only for type 1, right?
Yes. Yes. Now, type 2 diabetics do not need to take the shots. They are producing insulin, and they will take medication typically that will aid their insulin production or the uptake of sugars into the cells.
What's their
Okay?
issue then?
Sorry?
Type 2, what's their issue?
They make too much insulin?
No. They also don't make enough, or it's not good enough, but there's enough that with some help, with medication, it's able to work. Okay?
So they're not getting insulin injections like type
They're not. If they're type 2, they're on some sort of oral medication. Okay? So that's that. Now, long-term effects on diabetes. So the ones I want to talk about, you have here some nice pictures and things. I want you to know these words: polydipsia and polyuria. I think you should know these words. Okay? Polydipsia means that they want to drink a lot. Poly means many. Dipsia, thirst. So polydipsia, a lot of drinking. Polyuria is increased urination. Alright, which you may say, well, obviously if they're drinking more,
Yeah.
they'll need to urinate more, right? But they are actually two separate parts of the symptoms of a diabetic. I've had many cases where either I get a phone call or I go to a patient. Tell you one quick story. Went to a little 8-year-old girl, and she'd been for 2-3 weeks backwards and forwards to the doctor. 2 weeks. Mom just doesn't know what's going on. Doctor says it's a virus, the bloods came back normal, backwards and forwards, okay? I come in there, and I ask Mom a few questions, okay? First of all, I look at the girl.
Why did
I
you
see-
get cold?
Because she wasn't feeling well for 2 weeks. And now she's just at wit's end. She doesn't know what to do. Doctor keeps saying it's a virus. She'll be okay. Meanwhile, the kid is really not well. We'll talk about signs and symptoms and all that stuff soon. I come there, I see that the child has very red skin, number one. And I asked Mom, has she been very thirsty? She says, yeah, she doesn't stop drinking. She keeps asking me for more and more drinks all the time. I said, what about urination? Is she increasing urination? So Mom tells me, not in front of the girl, she tells me that last night, it's an 8-year-old kid, the girl wet the bed for the first time. She doesn't remember how long. Like, this is not a kid that would do that. She wet the bed in the night. I said, I know what's wrong with your child. I said, I know. I said, unfortunately, I'm going to do a test now, a blood test, but I think your child has diabetes. And I did a blood test there with the glucometer, all right? We spoke about that. And it was way high in the 500-600s, okay? And it was completely missed by the doctors, because it's something we think about in emergency medicine, but not something that your regular doctor thinks about. They think about infections and viruses and, this type of thing. Completely missed it. All right, I asked a couple questions, and I was able to pretty much make a diagnosis.
What were the first issues that they brought up to you? The drinking? That was the first
Yeah,
one?
one of them, yeah.
Is
All
it
right.
possible to be a diabetic with a lot of drinking but not necessarily urinating that much?
No.
Or they have to both?
They come together.
Where's it
No,
go?
why is it very common when it's not treated well or taken care of,
Drinking a lot,
that they lose their
urinating.
extremities?
It's called diabetic neuropathy.
With what?
Okay, diabetic neuropathy. Things start to fail. Things don't get all the way to the extremities. All right, I don't want to get too much into that. There's way more important stuff, and we need to hold the question or post it. So, this chart, everything on this chart, you need to remember. You need to know everything. You have this chart?
Yeah, but
Yeah.
you skip, going back to it?
No.
You skipped two things.
So, okay.
I did.
You have this chart?
Yeah.
Yeah, we got it.
Good. Everything on this chart you need to know and you need to remember and you need to learn. So here we go. There are two emergencies that you can find when you get to the scene with diabetes. Two completely separate emergencies. Now this has nothing to do with type 1 or type 2. Nothing, forget about that. That is just how we're classifying the patient.
You're saying both could happen in both?
Right, right. Now we're going to deal with what is the emergency, okay? And we just divide it by hypoglycemia, which means low blood sugar, and hyperglycemia, which means high, excess of blood sugar. Remember that all these names, when we talk about hypo or hyperglycemia, we are talking about the sugar in the circulating blood. We are not referring to what's going on in the cells.
There's too much sugar or too little sugar? You mean?
Yes, in the blood.
How does this relate, the hypo and the hyper, to type 1 and type 2?
It doesn't. Forget that. Forget that. No,
Both
nothing
can
to
happen in
do.
both.
Your patient could be a type 1 diabetic, could be a type 2 diabetic, doesn't matter. Now we're dealing with emergencies.
So they can have the same symptoms and it's the same
Yes.
problem,
Forget about the names. Those are just names of different
the
diabetics.
source of their
This
diabetes.
is Bob and this is Todd.
But they both are hypoglycemic.
But they could both get hypoglycemic or both get
And one is
hyperglycemic.
because it's type 1 and one because it's type
No, nothing. Nothing to do.
Can't bring in thing 1 and thing 2.
Okay? These are the emergencies that you will see in the streets, in the field. Okay? Don't worry about what name of the disease was. Okay? They're diabetics. Or maybe they're not diabetics yet. Either way, doesn't matter. Okay? But you could see either of these emergencies. So, I'm going to start with hypoglycemia. This is the most common diabetic emergencies that we see. And remember, what are we referring to by this word?
Less.
low.
Low sugar
Circulation-
where?
circulation-
In the blood.
In the blood.
In the blood.
In the blood. Remember that. Low sugar in the blood. Hypoglycemia. So, the first symptom we may see is
AMS.
AMS, right? And that's what we were talking about, ultimental status. They're not acting right. Now, if we do a glucometer stick, we're going to get a low BGL. BGL means blood glucose level. See, blood glucose. It's going to be low. What did I tell you low was? Below?
80 or 60.
Below 60 now, used to be below 80.
But
Very
no
good.
money and then.
Now, another piece of information that you're going to know, because they have low blood glucose, they have in the blood what? High blood insulin. What does that mean? That means that they have loads of circulating insulin. It's flying around the bloodstream. It's opening up all the channels.
There's no sugar.
There's no sugar. There's no sugar to go
Not enough
inside.
sugar to fill up the.
No sugar,
The
right?
glucose?
Yeah.
Sugar to glucose, same
Is
thing.
high blood insulin a ratio, or it's higher than normal even if there was
A lot of
regular
mashpiyim no makabel.
PGL? When we say high
Yep,
blood
it's
insulin,
never
is it high
happens
blood
in this
insulin in
kind of-
relation to the blood glucose level, or is it high blood insulin even if their blood glucose level is normal?
If their blood glucose was normal, then there would be enough sugar to go in and we wouldn't consider it high.
So,
So
it's
because
a
this is
ratio.
low, this is
So it
high.
is a ratio. It's,
Yeah.
it's in relation to it.
Every insulin receptor gets used up
Yeah,
when it gets plugged in?
yes.
A lot of
Let
mashpiyim
me
no makabel.
keep, yeah. Let me keep going and the questions will get answered. Just let me keep going. A big sign that you will see with hypoglycemia is when you come in to the patient, the family or the people around them will tell you that he was fine a half hour ago. He was fine 20 minutes ago. All of a sudden, boom, like a light switch. We call this rapid onset. Rapid onset, okay? Again, all these are signs of hypoglycemia. Skin will often be cold and clammy skin.
Which can mean
It could mean anything, but again, when you put it all together. And the other thing here, rapid onset, rapid pulse. You'll often have a rapid pulse, which I know could mean a lot of other things, but you may be told that this is a diabetic. You may be told that he wasn't feeling well and didn't eat properly. Okay, we'll get to more of that soon. First, the signs and symptoms.
Adults, same.
Same. I want to get all the signs and symptoms and understand them. Again, hypoglycemia, rapid onset, rapid pulse, cool clammy skin, low BGL, AMS, and obviously high blood insulin circulating because there's no sugar to fill. These are what you will see very often in the streets when on an EMS ambulance. You'll see this often. We'll talk about a little bit in a minute why, when, how this happens. For now, I want you to get these concepts. Next, the opposite, hyperglycemia. Again, the patient very commonly will be AMS, not acting right. Now they've got a high blood glucose level. High PGL means anything over 120. Dangerously high would be, 500-600s or whatever. But high BGL.
It causes low blood insulin.
Right. So there's no insulin in the blood, which means that all the sugar just keeps circulating in the bloodstream. It can't get into the cells. Remember the picture, the lock and the key. So it can't get into the cells. This has a slow onset. This patient has not been feeling well for a few days, for a week, for a month. Okay? Slow. It's been building up, gradual. They have warm, dry skin.
Regular.
Okay? Well, no, drier than usual. Even the usual sort of moisture of skin may have gone. Polyuria, polydipsia. These are the ones that get the need to drink a lot, thirst, and urinate a lot. Kurzweil's respirations get to in a second, and acetone odor on breath. So, we'll get to it. Acetone odor on breath. So let's explain what's going on now. Let's explain this one. Okay? As the cells are starving for sugar, right? Because where's all the sugar? In the blood. Cells got nothing. Okay? So the cells are starving for sugar. The cells have a backup plan. The backup plan is that they can burn fats that are able to get into the cells. They burn off fats and they convert fats into sugars. If you look at the chemical of certain fats and sugars, there's a very close similarity. So the cell is able to take a fat molecule and turn it into sugar. Remember, it's starving for sugar. The cell needs that sugar for it to stay alive, to produce energy, etc., etc. When that starts to happen, there is a byproduct that is bad. And those are called ketones. So the byproduct of fat being converted into sugar by the body, by the cells, is the production of ketones. And when this gets really bad, this hypoglycemia, you don't see this often, but when it gets really, really bad, they can go into something called DKA, diabetic ketone acidosis. And that smell of acetone, acetone smells like the polish remover, okay, that some of your wives use, or maybe Ari, you know.
Breath smells like?
Yeah, you can actually smell
Can
that.
a patient smell it or taste it, that thing, or they won't know?
They probably won't know, they're probably sick and
So they're getting, it's a
AMS.
slow onset, they're used to it by the time it's
So, again, this doesn't happen fast. DKA takes a while. So the patient now is producing. Hmm?
Would they lose weight as a result because it's burning fat?
No, they're drinking sugar drinks and they're just no.
There's a reason why they're hyperglycemic.
Yeah,
Right, the sugar drinks, it is making it worse.
it's making it worse.
Because they're all, they have tons
It's
of
just
sugar.
circulating more sugar. It's
It's
putting up the BGL higher and higher.
But why is that bad? If the issue are the cells converting, it's not that, it's a never mind.
Okay? Wow, good. He answered his own question. I like that. Next time, post it.
And then he writes,
That'd be very long.
So, again, DKA, diabetic ketoacidosis, this is not a common thing. This you may see, a couple times in a career, all right? But this is possible. They will have this acetone odor on their breath, and because they are producing acid, in the body cannot be acidic. Okay, it's a very particular pH that the blood has to be. They will do some funky breathing. And it has a name. And it's called Kuzmo respirations. Not a sound, it's irregular breathing pattern. I don't want to go into it now. This is all you need to know. Okay? Again, irregular breathing pattern, and it has a name, which EMTs are expected to know. Kuzmo respirations.
Is it an acronym?
No, it's not an acronym. No, it's just a name.
The janitor.
Alright? Kuzmo respirations. The reason it happens is because of the DKA. Okay? The reason the acetone odor on breath is because of the DKA. Why do they get into this problem? What's happening? These are things you'll be tested on.
DKA.
No, but what's happening that causes DKA?
Cells are converting the fat into sugar.
Good. Cells are converting fats into sugar. They're making this ketone as a byproduct of that conversion. Those ketones are acidic. The body has to have a very specific pH, which we don't go into that in EMT school. Stay tuned for medic school if you want to learn more about pH
We know
and
the dates after class.
all that stuff.
What's
So,
pH?
not now. How much acid or alkaline is in a body? It's a measure.
Is that, is the AC, what was the bottom thing? The acetone.
Acetone.
Is that an uncommon symptom because it's just an uncommon symptom of this, or it's because it's very late on in the...
Yes, it's very late on in the problem. No, it's part of hypoglycemia,
You said it will be...
but it's uncommon that you will see it
because
in the
it
field.
happens so late.
Happens so late and after so
generally,
long.
they would be taken care of by then.
Yeah, usually.
But it comes together with the issue.
Too long on the
getting worse.
slide.
Yeah. There is one more thing that I want to say, that sometimes with hypoglycemia, there is something called a fruity odor. Fruity odor, which you may have seen in your reading,
Get that one.
okay? And that sometimes happens with hypoglycemia. Don't confuse the fruity odor
And the acetone.
with acetone.
So don't just like give them more sugar.
No. Okay? Right, let's look into what happens. So, hypoglycemia, we know the signs and symptoms. Let's look at the causes. Now, usually the cases that I have been to, and it's been a lot of them, usually what's happening is they take their insulin, like as they're supposed to, and they don't eat.
You don't eat before or after?
After. They have to eat after they take their insulin.
Why?
The way it's set up is that when they get an insulin shot, what's happening in the blood? The insulin levels are rising up. What's going to happen to the sugar? It's all the sugar that's circulating is going to be
Into the cells.
into the cells.
They need more sugar.
Now they need more sugar. It's that simple. So they must eat every time they take insulin. Now, insulin has changed over the last 20 years tremendously. They used to have to take it before every meal. They used to take it morning and evening. Then it became just take it once a day. Then it became, now there's such a thing once a week even. So they've produced better, slower acting insulin, which means that we get less calls. Okay? But what used to happen was, especially with younger people, what used to happen was that they would take their insulin, say a teenager, take their insulin, okay? And then a friend would come over, let's go out, let's play ball, let's do this, let's do that, skip a meal, and boom. And then they go down, or they have this whole hypoglycemic crisis wherever they are because they took their insulin and they didn't eat. They didn't eat. So the way it was that the doctor would average how many units, insulin's measured in units, how many units of insulin a person needed based on their average intake of sugars throughout the day. This is managed by special doctors called endocrinologists. They manage this stuff. This is what they do. They would tell a patient, okay, take this many units in the morning, and because you don't eat so much, and then this many units at night because you have an average amount of the foods that they eat. When diabetics get sick, and I mean sick, I mean flu, random colds and whatever, all bets are off. Everything can go out the window. All their normal levels, and then they get these emergencies.
That's because they don't have, because they're not getting enough food to.
Because they're sick. Everything goes slightly funny, okay?
Is that why they can't, is these the kind of people that can't fast and things like that?
Yeah, these people, many of these people that have this hypoglycemia don't fast, not allowed to fast because they have to take their insulin and then they have to eat. Okay? They're better off, the ones that really want to be frum are usually better off not taking the insulin,
Suffer a little.
suffer a little bit that way, and fasting, rather than, if they take it and don't eat, they'll be in big problems.
If someone like that doesn't take their insulin, what happens to them?
So, we'll get to that. We'll get to that. That's not on this slide.
Put your heads up, old guys.
Okay? So, hypoglycemia again, low blood sugar, and we know the signs and symptoms. Now, here's the opposite effect. Okay? Hyperglycemia, which can lead to DKA. Doesn't always, alright? It can. So, what happens here? What happens here is they just didn't take their insulin. Okay? Or they didn't take enough insulin. Here's what happens. They took their regular insulin, their whatever, 40, 50, 60 units, whatever they're supposed to take, and now they go out to a birthday party. The birthday party, they're serving burgers, fries, birthday cake, all sorts of good stuff. Their doctor gave them enough insulin for, meatballs and spaghetti, for example. Okay? Now they're eating ice cream and donuts and,
Sushi.
right? All this good stuff. So, not enough insulin. Whatever insulin there is going to obviously work. It's going to bring the sugar into the cells. Now, all they're doing is increasing the levels of sugar circulating in the blood. And there is no way to get that sugar into the
But
cells.
it takes a long time.
It takes a long time for serious consequences.
So you're not going to get called to a birthday party.
A hyperglycemia
Rare,
has
unfortunately.
their own natural insulin. Too much. Is that correct?
Guess it's better than ruining the
The
birthday
hy-
party.
the
You just
hy-
go
hy-
home
hy-
and get
because,
mad.
No, you never. These people don't have their own natural insulin
So why are you showing that he has too much insulin? I don't know.
because he took his
He
shots,
took a shot.
Took the artificial
He
insulin.
took artificial insulin.
but not enough, or he didn't take it at all. Read. Did not take insulin or did not take enough.
Whatever
That's
it is,
why.
the result is too much sugar in the blood.
Look, that's why I put this in front of those pictures, because this I made. It makes much more sense.
Yeah, yeah.
Wait till you get to the last slide.
And then the movie.
Okay? Alright? So, this is what you need to know. You will be quizzed and tested on this stuff.
On this stuff?
All of this.
All of this?
What do I have?
Everything.
Diabetes.
How do we treat, oh, looks good, a nice picture. How do we treat
From the other slide.
diabetes?
It looks like a desk in this. It looks like a desk in this room.
Looks like his desk. Put in a
Yeah, it looks like a desk in this room.
That, hey, that looks like my highlighter too.
How do we treat diabetes?
Sugar.
Yeah, well, sugar is probably a good thing to do. Look for medical alert bracelets, necklace, foot, ankle thingies, right? Medical alert bracelets are really good. They'll tell you, you know, it says diabetic, type 1 diabetics, usually what it'll say on it. It's really easy. And yeah, oral glucose, that's what you want to be giving them as long as, what's the big,
They could take it down.
yes, how do we say that like grown-ups?
They're conscious.
They're conscious,
My bad.
excellent, right? As long as they're conscious, they have an intact gag reflex, you can give them oral glucose. And we spoke about that during pharmacology, how to actually administer that. Remember here, see, patient is conscious, patient has gag reflex. It's all there.
OPQRST.
Yeah, you haven't learned that yet. We'll get
That's
to
a
it.
medical assessment.
Very
Okay,
curious.
we'll get to that.
That's a medical assessment.
So,
Whatever.
so now the change, if you like, to this slide is that now you as EMTs are allowed to use a glucometer,
So
okay?
you know which one they.
And you're allowed to know if they are. In New York City, again, they say if it's above 60, withhold any treatments, okay? But if it's 60 to 80 and they're AMS and showing signs of hypoglycemia, give it, obviously. But they're saying now 60, they dropped the number from what I would have told you, 80 to 120. Okay. Are we good on diabetes?
Great.
A lot of information.
A lot of information.
Okay. Seizures. Seizures. So a seizure after seizure. Seizures is involuntary change in behavior or movement. Seizures are electrical impulses that are firing in the brain and telling the patient or the brain, the person, to do various things. But this is not voluntary. These are things that they don't particularly want to do. Seizures send electrical impulses through the nervous system and cause all sorts of problems. Now, common causes, I listed a few here. What I want to mention is this one, febrile seizure. You can write next to that the most common form of seizures in children. Okay, so that's a good thing to write in there. Febrile seizure is the most common cause of seizures in children. And we'll talk a bit more about that when we do
My
pediatrics.
nephew had one of these.
Sorry?
My nephew had one of these. He was running a high fever
Yeah.
and he's
We'll talk more about that. CVA or stroke, we're going to do a lecture on that tonight. I like this one. Idiopathic. So if ever you hear a doctor say, well, it must be an idiopathic reason or cause, that means he is an idiot and he doesn't know. That's the way we say in medicine, we don't have a
Nobody can
clue.
figure that one out.
We can't figure it out.
Fifth disease.
Right. So when they try to sound very sophisticated and they want to say something that you'll just be like, oh yeah, oh, okay. Right? So they will say things like, it must be idiopathic.
Sure,
All right?
no one's gonna
They
get
don't
that one. No one's gonna get that one.
All right.
I mean, I don't have a clue.
All right, not a
You're an
clue.
idiopathic.
So, and this very often is the case for seizures. The couple things here, head trauma. So you'll see this, head trauma. Patient sees after major head traumas, okay? It's something that can happen
How does it get an electrical impulse to do that?
because the whack against the brain hitting the skull, one thing or another, is causing the seizure to happen.
The brain has electrodes that go through it.
Well, they're neurons and the whole nervous system.
There is something there, so this is just knocking it out of whack.
Yeah.
Wait,
Okay? So, different types of seizures, things you must know as an EMT. Generalized seizures. There are two types of generalized seizures. Okay? Petit mal, also known as absence seizures, same thing. Petit mal, also known as absence seizures. These are typically seen in school-aged children, and they sort of gaze off into outer space. Okay, it's not a daydream. They can be completely out. They're sitting in their chair, and their eyes shift to one side. This is typically diagnosed by a good school teacher, who will then have the child seen by a doctor, who will then send them to a neurologist, and they will try to figure this out. They don't usually last forever. They don't usually last into adolescence. They usually go away. These children should be seen by a neurologist and have it all worked out. They're called absence seizures or petit mal seizures.
It goes away after a while.
They usually go away. The one we see in EMS the most often are these, which are known as the grand mal. Grand mal, French for very bad, or petit mal, little bad, okay? And these we call grand mal. Okay? No, we will not pronounce French words correctly because we don't like them, all right?
Thank you.
Tonic-clonic seizures.
It's all good.
Okay? Tonic-clonic seizures or grand mal seizures. Know both names. Okay? And we'll talk about this in a minute. Here's a decent picture that sort of shows you a partial seizure. It's happening in one small area of the brain, whereby the generalized seizure is happening all over. Okay? That's really the difference. Now, there are things called partial seizures. In EMT school, we don't need to get into these too much. So, partial seizures, part of the brain is having the problem. Complex partial seizures, again, we're not going to really get into this. What you need to know about are generalized seizures, and there are two types. Again, what are they? Petit mal or absence seizures, and the other one are called tonic-clonic or grand mal
What
seizures.
does tonic-clonic mean?
We'll get to it. I will tell you. Here you go. Look, it's all here. Petit mal or absent seizures, I told you all this already. Good. Tonic-clonic. These are the ones that you see the most common in EMS, all right? These are the ones we see the most often. Tonic. Tonic, these are three, there are really possibly 4 phases to the seizure. Okay, you have here 1, 2, 3, 4. Okay, this one, not always. We'll get to it. These 3 are always part of your grand mal seizure. So what are they? Tonic is something you will almost never see in your career as an EMT. You'll almost never see it. Unless you're sitting in shul or at a ball game and the guy literally next to you begins to have a seizure, you may witness it. But otherwise, you'll never probably witness the tonic portion. Tonic is where all the muscles, all the skeletal muscles, right, they tense up and the patient falls to the ground. Now, the good part about seizures, if you could say that, is that many patients that have seizures may get this aura right before the seizure. And I have witnessed the
Aura.
not the aura. I've witnessed the result of this aura many times. I'll explain. They get some sort of feeling or hallucination or something that they're about to have a seizure.
People that
They
have
know.
chronic seizures know when it's coming on, and
That's
they,
what
they
it
can
is.
brace themselves and stuff.
That's
like
what he's
that.
saying.
No,
That's
it's,
what it is.
they train dogs to see these. There are people that have.
But there are people that have
That-
chronic.
They have
that
it
is.
is.
and they
That's
have
what it
dogs
is.
that can sense
But they can
So,
sense that.
there are dogs and cats that can also sense this aura before it happens.
What is that aura?
It's a little halo.
So, this is a hallucination or a feeling. We don't know exactly what it is, but they know, they have some sort of feeling that they are about to have a seizure. And for that reason, 99% of the people I've been to having seizures are found in safe places. They're in bed, they're laying on the floor, they're on a couch. It's amazing. They're not walking downstairs and then start having a seizure and fall down and bump their head and cut their head open and all this. You don't see this. Very rare someone has a seizure in the middle of the escalator, going all the way down to the middle of the world, okay? They don't happen
Do they sometimes
because
cry out?
they often get this aura.
Do they cry out? Like they make an audible sound at all?
No. They put themselves in a safe place. That's usually all they have time for. It's very little time between the aura and the tonic phase. Very little time. Okay? So, like I say, most of the seizure patients, and I see a lot of seizure patients, they mostly in bed. They got the aura, they went and lay down. What the time is between the aura and the start, I don't know.
You never know.
Okay? What exactly happens during the aura, I don't think we know. All we know is that they have some sort of nevuah, if you like, hallucination, knowledge, feeling, whatever you want to call it. And yes, I had students telling me that they had animals and their mom would seize one thing or another, and the animal would start going berserk and jumping around the room,
Having a
and
seizure.
they knew that there was a seizure coming from the animal.
But people have this chronic issue. They travel with trained animals.
Yeah.
So this
But there
aura
is
by
characteristics to the aura.
specific seizures or?
No, they could all be different. For the tonic-clonic.
They could, but sometimes they're characterized as smelling something fruity or.
Again, they're different for everybody. They have different ways of knowing. Okay, I ask the patients often,
What do they?
and sometimes they just say, I just knew I had to lay down. I just knew I had to lay down." That's all they say, stuff like that.
Could anybody past 18 play the same? I just have to lay down.
Okay, that's on a regular basis. All right, so tonic again. Tonic means that all the muscles in the body tense up, and usually, if they are standing, they will
Sit down.
Collapse.
collapse.
So
Does
someone
that always
gets-
happen? They always have the tonic phase?
Always. Okay? After tonic is clonic. Clonic is the rhythmic shaking or the convulsions. You may be familiar with that word, convulsions. Okay? And that is, it's not all over the place. It's not, like this, people think. It's very rhythmic, a seizure. Very rhythmic. Arms, maybe legs, maybe eyes. Okay, these are all places that you should be looking. But it's not just flying extremities randomly. Yes.
You said, so every seizure starts tonic automatically?
Yeah. Every
But it's so-
grand mal seizure.
But it's so quick that you never,
The tonic part takes a few seconds.
Are there
and then
people,
they'll go into convulsion.
Yes.
are there people who get this all the time?
Epilepsy.
Yeah, people with epilepsy can have this quite, but they take medications to. Let me just finish explaining it, and then you'll ask your questions. Yeah.
Or send it in.
They take the rocks in.
Let me try to finish, guys. Let me finish, and we'll get to the questions. I will answer all the questions, but let me talk. I will probably answer it. You've got to know these phases, by the way, what they are, when they happen. The third phase of every seizure. When I say every, I mean grand mal, okay?
And petite Verdot.
No, not.
Just grand mal.
It's a wine.
Come on, get your
Just
friends
tonic-clonic. The third phase is called post-ictal. It's written here. Post-ictal. Okay? Post-ictal is a deep, sleepy, coma style. A deep coma style slumber that they go into. Okay? It is part of the seizure. Very often, this will be the part of the seizure you will see. If you're really quick, you'll get there in time for the clonic phase. You got to be really quick. How long does the clonic phase last? How high is the Chinaman, right? We know that. So there's no answer. So, post-ictal, how long does that last? I usually say it lasts about the length of the clonic phase. It can last longer.
What is it?
Right. What is it? It's a sleep. They go into a sleep, coma, whatever you want to call it. Somewhat. They're breathing, their heart is working. Okay?
Total system restart.
Like a total sleep. But you expect to see that. Expect to see that. Meaning, if somebody tells you, oh, hi, yeah, I was just seizing. I'm like, okay, when did your seizure stop? Oh, yeah, about 30 seconds ago. And, you know, they probably never had a seizure. Or they may have had a seizure, but not a grand mal seizure. Okay? So for grand mal, we're looking for these three things. Tonic, which you probably won't see if you're part of EMS. Clonic, which you won't see if you ride 911 New York City, but you will in Hatzalah. And post-ictal, which you may miss also if you're in 911 EMS.
Do adults get petite mal at all? Or
I've never had a case of it. Okay? Right? Post-ictal, which, you know, may be in the 11, 12 minutes that it takes EMS to get there, they may be coming out of the post-ictal phase already.
Now people think that they're fainted or things like that.
Well, people around them, again, a girl goes away to college, she's in some dormitory, the person looking after it doesn't have any medical knowledge, doesn't told one thing or another. All of a sudden, she's laying in bed, the kids come in and say, oh, why isn't, Sally responding? Maybe she's dead, right? 'Cause they don't know the difference. So, you have stuff like that. We'll talk about how you can backtrack. We'll talk about that in a minute and figure out that she possibly had a seizure. The other way is that you come in and they're with people that they know.
So, but you can't wake them up from that.
No, better not to. Let them come through by themselves.
And they're breathing.
Breathing and everything. We'll talk about some of the problems in a minute.
Is there AMS when they awake from this?
No, they usually wake up and they're pretty much not AMS. They're pretty with it. They're a bit
confused,
groggy.
A little confused.
They might be a little confused for the first minute or so, but they're pretty much they're back in the room.
And
They're pretty much back
Do
with
they
you.
know, like, if they had it before, they probably know, like...
Yeah.
Who gets these seizures?
Well, children with the febrile seizures, people that got head injuries, or people that have status epilepticus. All right, status epilepticus are epileptics. All right, the real medical term for it is status epilepticus. Okay, the definition of that is when a person has a seizure, tonic, clonic, postictal, does not become lucid, and right away goes back to tonic, clonic, postictal. 2 or more seizures concurrently, that would be stat-ep. Status epilepticus, or just stat-ep is how we call it for short. Had a case of this in the country. We went to Bungalow County. There was a teenage girl. She was seizing. We were going to stop the seizure with medication. All of a sudden, she stopped by herself. She went into postictal phase. Okay? We figured, all right, let's move her. So we brought in a border stretcher. Boom, 1, 2, 3, got her into the ambulance. Soon as we got back into the ambulance, boom, started again. Full clonic seizure, started all over again. This time I had the meds and I stopped it because we don't want to let seizures go on for too long, and we didn't know exactly how long she'd already seized. So pretty much our protocol is, if you see it and they're seizing, stop the seizure.
But that's ALS though, right?
Yeah, that's ALS. Yeah.
2 or more or 3 or more makes it a.
2 or more.
Does it matter?
Yeah.
But anybody who
So I read 3.
slams their head into the concrete can get a seizure?
Yeah, but that would be a one-time thing. They probably won't become
They wouldn't develop.
epileptics, right? They won't become stat-ep. Now, very important thing is to note that patients become incontinent. We know what that means? Post it on the group if you're not sure.
It doesn't work.
Yeah, you turn
It
it
has
off.
something to do with the meridian.
No, I'm saying that's the Q&A session's closed.
No.
You're saying ask a question at Google, that's what, that thing?
Yeah.
No, it still says.
So the Q&A session's closed.
Yeah.
What may work?
One.
Too many questions.
I had many questions already.
That's still open for me. I'll ask you a question. All right,
Okay.
Sean?
Billy's fresh.
Okay. So, patients may become incontinent. It is common, more common than not, that they become incontinent during a seizure. So when you're moving them, right after the seizure, ASI, okay? Because
Weird glove.
if it's wet, warm, and not yours,
Don't touch it.
don't touch it. Very good.
Just don't eat it.
You don't want to do it.
What did I want to talk about?
You don't have banana.
Sushi.
Usually, these patients that have the tonic-clonic seizures have a diagnosis of epilepsy. Usually, they will be on various medications for anti-seizure medication, and these levels need to be monitored regularly. They go in, they get blood, they test the levels, and then a doctor, neurologist usually will play with it and adjust it so that they don't have these breakthroughs.
What kind of intervention could BLS do?
Get to it.
Oh.
We might get to it. Why can't I change the page?
Battery. Too long.
Hope you close the chat.
Maybe the battery.
Oh, it's open.
No.
Just died, Ellie.
Why?
Pause this first.
Froze.
Complex partial seizures. These are usually happening in one hemisphere of the brain. The brain is divided into 2 hemispheres. You're not really going to have to get into this too much, okay? What I want you to focus on is the grand mal and the petit mal seizures.
Clicker time.
We're back. Treatment of seizures. So what can the EMT do?
Nothing.
Okay? Well, there's more do nots than do yes. Okay? So let's start with the do nots. Do not place anything in their mouth. I know. I don't want to know. No. I know. Do not, let's do this one again. Do not place anything in the mouth,
Ellie's not listening.
especially your fingers.
I'm asking a question.
That's fine. Do not put your fingers in or near their mouth. They have superhuman strength. They can take your fingers off. Do not put them in their mouth. Do not restrain the patient. Do not say, oh, we need to tie this one down. No. Now, what you should do is to protect the patient. Protect them from themselves, from dangerous articles that may be around them. That's what you need to do. If they have airway problems, no, they're not awake. They're completely unconscious. What if they are seizing and there's a glass vase 6 feet high and that's what they are kicking on?
You restrain
Right?
the patient.
It may be good to move the vase or the patient away. One or the other. Fantastic. Airway. Airway is always a problem. One thing that you see,
How do you maintain the airway?
one thing that you're gonna see,
You're not placing anything in the mouth.
good. One thing that you're gonna see very commonly with a seizure going on is blood and drool coming out of the mouth. Now, when you get unseen, one of the first things one of the bystanders is gonna tell you is, oh, look, they're bleeding, their mouth's bleeding, right? Meanwhile, they're seizing, they're burning brain cells, but they're worried, the people are worried about a little blood that's coming out of the corner of their mouth. They typically bite their own tongue while they are seizing. It is extremely common that they bite their tongue or they bite the inside of their mouth while they are seizing. So yes, there will be some blood. That is not your worry or concern. Your concern
You can bite the tongue
is
off.
keeping people away. Don't put anything in their mouth, right? Don't restrain them. If you need to worry about airway, all you do is turn their head to the left side. That's what you can do. Do not put anything in the mouth. Do not suction them while they're seizing. Okay? Do not do any of this stuff.
Approximately how long do these convulsions last?
How high is the Chinaman? I just asked that question.
That's similar to my question? No, that's.
How long do they lose before they get knocked out?
Sushi.
No, I was
Just
trying.
asking how does it change?
There is no answer to that question. Okay? So again, medics can stop a seizure with benzodiazepines. That's a group of drugs that we can use. EMTs cannot. EMTs have to keep the patient safe and worry about the airway. Now, if they go post-ictal and you're worried about the airway, you may try to suction some of the mouth while they're post-ictal, if you're able to. You may want to insert an OPA, but you're probably better off not. Okay? Roll them onto the left side, let them get over the post-ictal, they'll come back, and then you'll figure out what to do.
So as long as they're on the side, you know, don't worry about them.
Right.
working.
Right. CVA. CVA, cerebrovascular accident. This is the name we use for stroke, CVA. Now, strokes come in two flavors. They come in thrombolytic flavor, and they come in hemorrhagic flavor. We're going to get into both of these and try to understand the differences and the similarities. So CVA is the word we use for stroke, okay? And there are two types. Thrombolytic. Think of a thrombolytic stroke as an MI in the brain. That's really what it is. There is a blockage in one of the cerebral arteries. That blockage is preventing part of the brain from perfusing, therefore causing a CVA. We'll get to what it is and one thing another. The other one, which unfortunately does not have good outcomes, these people typically die within anywhere from an hour to a day to a couple days, whatever. These are called hemorrhagic strokes. Hemorrhagic strokes, typically there's an aneurysm, which is a weakening of one of the arterial walls in the brain. It bursts, blood then flows out. And one thing I think that we know when we did head injuries was there is no room in the skull. The brain and the skull fit like a perfect match. There's no extra room as blood starts pouring into the skull, and it's very, very difficult, depending on where the hemorrhage is, to get in there. And you know, you can't just open up a little skin and clamp, and you know, there's a skull. So it's very difficult to get in there. There are surgeons that will try to operate based on age and you know what they see on CAT scan, the size of the hemorrhage. There's a million questions, but most of the time.
You saw that video of that kid by his bar mitzvah last week?
Seizure?
No, they were flipping the kid over,
on his head.
dropped him on his head at his bar mitzvah.
Yeah.
He had a brain hemorrhage. He left the hospital a week later.
Okay.
He was left.
So it's probably a very, very small, leak of one of the vessels. These are the ones, again, you won't necessarily know which one your patient is having, but your job is to recognize the CVA. Actually, I'll go ahead and use the word diagnose the CVA. I'll let you do that. And get the patient to an appropriate facility.
The hemorrhage doesn't come from trauma or anything?
It may, or it may not. Okay? So, get the patient to an appropriate facility. In New York City, hospitals are deemed and known as stroke centers or non-stroke centers.
Kings County.
If your patient is having a stroke, you want to get your patient to a stroke center. Most hospitals are. There was a time when most were not. Now they're coming into line. So again, two types of stroke: thrombolytic, think of those as an MI in the brain, or hemorrhagic. Now, stroke was known as many other things. It's called stroke in America. This one, brain attack, was a concept of the American Heart Association. Many years ago, they decided, since Americans know what a heart attack is, maybe we can teach America that heart attack, chest pain, brain attack, the following symptoms. The name didn't stick. Americans still don't know what a stroke is, but they're still calling it a stroke. All right? This has come now into use, especially in New York State. And it's NTBI. It stands for a non-traumatic brain injury. Non-traumatic brain injury, the opposite of this would be a TBI, a traumatic brain injury. These terms are being used now in New York State and on exams and quizzes and tests, okay? So, non-traumatic brain injury is pretty much a stroke, as far as you're concerned.
Why is it considered non-traumatic?
Slide over here.
If it could be, oh, you saying because it wasn't caused by trauma?
Non-traumatic because it happened just because.
Meaning it was an inside source, not an outside
Yeah.
source.
Cerebrovascular accident, you must know this word, and it is shortened to
Can't pronounce it.
CVA. Yes, you can. Cerebrovascular. Okay, it's on another slide. It's all in there.
We're gonna send Jeff a piece of our mind about not having updated books over here. This is really,
Signs and symptoms. How do we know that somebody may be having a stroke? Well, they may be AMS, right? Person may call in and say, Bob just ain't acting right. They may have a headache, and when they say headache, the thing to listen out for is if they say it's the worst headache of their life. Okay? Just like with the impending doom of an MI, there are certain things that they say that tip you off. Here, they may say these words, the worst headache of their life.
Could just be a migraine though.
Yeah.
It could be, but if they don't have any history of migraines or any reason to have a migraine, we need to find out, are they having a stroke?
It's like elephant on the chest.
Right, unequal pupils. This is something that we know from TBIs, okay, from trauma, traumatic brain injuries. It may also happen in a non-traumatic brain injury. All right, hemiplegia, okay? This is weakness on one side of the body. Now, it could be the left side, it could be the right side. The actual face will be the contralateral side to the body, which means if the right face is having a problem, it'll be the left side of the body because the nerves switch in the middle, okay, in the neck. So, again, not something you'll really be tested on, just to understand, not to be shocked if you see a seizure and they have right-sided problems and then the left side of the body, right-sided face problems, left-sided body. Drooling, facial droop, we'll get to this, and aphasia. Aphasia is the inability to speak or other language problems. These are words you need to know. Hemiplegia, hemi means half. Hemiplegia, half. Paralysis, the one side of the body, right arm, right leg.
Hemi is half?
Half, yeah. And aphasia is the impairment or inability to speak. I'll tell you some stories maybe soon, but first let's see these signs and symptoms.
Hemiplegia?
Let's talk about some of the treatment. Oxygen is good, maintain the airway. Okay, these two lines there are definitely test questions on, so you need to highlight this stuff. Conscious patient in Fowler's, semi-Fowler's. Unconscious patient, left lateral. What do you think the reason for that is?
Because of vomit.
Right, we don't want them to aspirate. Okay, so conscious, conscious Fowler's or semi-Fowler's, unconscious left lateral. Protect the weak side. I'll talk more about that in a minute and go to a stroke center. So what is going on, okay? And how can you, or even an 8-year-old child, diagnose a stroke? We use something called the Cincinnati Pre-Hospital Stroke Scale. Okay, and that's what it's called. That's an official name, the Cincinnati Pre-Hospital Stroke Scale. Okay? What it does is tests 3 things. And you can have your patients do these tests as long as they're conscious. If they're unresponsive, then you're done. There's no way you'll be able to do this. You need them to be conscious. First thing we do is ask them to put their arms out in front of their face like this and close their eyes. All right? You want them to hold the arms like that for 20, 30 seconds or so. Okay? That's what you want them to do. Close their eyes with both arms out like this. Now,
This is part of treatment?
this is diagnosis.
Okay.
Okay? This is how you do it. You may see the following. They may put one arm out and the other arm doesn't move. You'll tell them, can you do both arms? And they will tell you, I am. Very often they think both arms are out in front of their face. You may see this, that they're able to put both arms out, but one arm will droop down. They won't be able to hold it there. This is test number 1.
You're putting pressure on it?
Nope, nothing. Just let them hold it there in the air.
Drunk people can.
Test number 2 is look at their face and ask them to smile. You're looking for a bilateral smile. Big smiley face. Both sides. Thank you, Harry. Very good. That's what you're looking for. Somebody having a stroke will not be able to smile bilaterally. There'll be one side maybe go up like this, the other side will just stay flat or even be down.
Could be a drunk person with Bell's palsy.
Okay. Number 3 is speech.
Maybe the chat's not working.
Okay. Number 3 is speech. For speech, you need them to repeat a sentence back to you. Okay? It doesn't matter what the sentence is as long as both you and the patient speak that language that you gave them to repeat. It doesn't even have to be appropriate. It has to be something that you both understand. It's no good you trying to break your teeth or giving them to say something back in Farsi if you don't speak it and you don't know if what they say is right or wrong. So it's got to be in a language that you both speak and both understand. Have them say anything. It doesn't matter what you have them say. You can have them say the rain in Spain stays mainly in the plain. You can have them say something much simpler. You can have them say today is Sunday, tomorrow is Monday. It doesn't matter. It doesn't even have to make sense. Okay? Just have them repeat something back to you. If it comes back, you can't teach an old dog new tricks, is another one people like to say.
This is part of the Cincinnati Pre-Hospital Stroke Scare?
This is part of the Cincinnati Pre-Hospital Stroke Scare. Okay? So, here's how you can diagnose a stroke. If they fail all 3, they're having a stroke. It's that simple. If they fail all 3, they are having a stroke.
And 1.
Okay? If they fail 2 out of 3, then their percentage of them having a stroke is very, very high. If they even fail 1, there's some 70-something% chance that they're having a stroke. No, that they're having a stroke. It's that good of a diagnostic tool.
Now, there's different levels of a stroke as well.
Well, it's different sizes of the blockage. There's different amounts of bleeding. There's different places that the blockage can be. So yeah, of course there are, but that's not going to help you pre-hospitally. That's only if you have a CAT scan. Your job is to decide, is this patient having a stroke, yes or no? That's it. That's your job. That is your job to do to help this patient. And if you think they are, then get them to a stroke center. Yeah.
My guys asked the lady to squeeze their hand.
Okay.
Any purpose?
That's fine. Yeah, that's another type
They
of...
suspect a stroke there?
Yes.
Yeah?
She could. He wants to take
It's another type of neurological... It's another type of neurological test. Again, these are already going into more complex details. The simple... No, any order you want. They say fast. Pace, arms,
Is this the test?
speech, and time.
Is this the test?
Yeah, absolutely.
Why is it so crucial to get them to the hospital ASAP?
Because, okay, so let's think now, what is the definitive treatment for stroke? Definitive treatment for stroke is a drug called TPA. Okay? Now it's very complex which patients can get TPA, which can't. One of the criteria is the amount of time from when they were last seen walking and talking and normal. So people who have a stroke in the middle of the day at the office do much better than people that fall out of bed at 7 o'clock in the morning and can't move. Because those people, we don't know when they were last seen normal. They may have last been seen normal at 9 or 10 p.m. before they went to bed. They had the stroke. We don't know if it was 10 minutes ago or if it was 10 hours ago. These people don't do well. They can't get the TPA. So there is a window. The window used to be 3 hours, moved to 4 hours. Now they're looking at 6 hours. But there is a window. Okay? So you need to get your patient to the hospital. The most important piece of information you can bring to the hospital with you is find out from the people when he or she was last seen walking, talking, moving, doing everything normal. That is the most important piece of information you can bring with you. You bring that with you, you can help to save this patient's life. Okay? Because if you come with no information, they've got no information also.
And they can't do it,
They won't do it. It's a very dangerous drug. It's a very dangerous drug for a number of reasons. I'm not going into it now.
If they give it beyond the.
Yeah. It's very dangerous for many other reasons also. Okay? But I'm not going into that. ALS does carry this in various states. In the Midwest.
What is it something, if it's something that you
ALS does carry this in various other states, not in New York City or New York State.
There's stroke centers everywhere.
That's exactly the reason why.
So we have basically nothing we could do for this besides get them there.
Oxygen and move. And there's nothing to call for medics for either. If their airway and breathing is good, there's nothing more I can do than you can do. We always get called. In Hatzalah, bless them, they always call medics like, we can do some magic. We can't. We can. We don't carry TPA. We don't have a CAT scan in the back of our ambulance.
Yeah.
Right? There's nothing more that we can do. However, if your patient is losing their airway, or they're having a breathing problem, and there's a stroke going on, absolutely call for us. We will deal with the airway and breathing.
That's what I was going to say. It can.
Again, doesn't usually.
Oh.
Okay, usually you'll get to a hospital within 10 minutes.
Do they recover?
Every patient's different. Every patient's different.
What do you mean time is muscle?
Meaning, the longer you wait for that while they're having this stroke, the more brain they're losing. It's like an infarct. It's getting bigger and bigger and bigger as oxygen is not getting to these surrounding areas. So time is muscle, meaning you don't want to play games on time. I'll tell you, I had a very, very prominent patient in my neighborhood. Big Rav. Very prominent. Okay? And he was in a meeting in the middle of the day, and he had a stroke. Nobody knew. Nobody knew. EMTs came, I came. He was walking, he was talking, got him into the ambulance, and I started asking him questions. And he responded to me with numbers. That's all he could say. Where are you now? 987341678. This is all he would say the whole way to the hospital. Every question I asked him. Numbers. Okay? That's all he was coming out of his mouth. And he thought he was having a conversation with me. That's aphasia. Okay?
What prompted them to call?
Oh, I think he was standing, he collapsed.
No. If it's the same person I'm talking about, he was in a meeting and he started speaking.
How long should you spend?
Did you
trying
just
to find out
violate
how
the
long
HIPAA?
they-
Yeah.
No, you didn't.
How long should you spend on
No,
the
you
scene
didn't
to try to
because you
find
spoke
out when
about
the
it
last time they were
publicly.
normal?
No, you didn't.
Do not, what do you mean how long should, this whole thing takes about 10 seconds.
No, to try to find out how they were before.
That's really important.
So
If
is
you
it-
need to spend like another minute to
Another
find
minute
out,
to-
spend it, yes.
He spoke last night in the speech.
Okay, he speaks often, alright? Speaks often in public.
About
He
it.
can speak? No.
Yeah, he's.
He's 100% fine.
100% fine.
100%. Okay?
Ellie saved him.
Yeah, I did.
Ellie gave him a little fentanyl.
Okay? I called the head of neurology at the hospital. I had him waiting for me when I got there. Okay? And yeah, we got him. He went to my manager.
They have a stroke, sir?
Absolutely, big time, yeah. Okay, and I have the doctor's cell phone number that I had in my. I called him. I said, "Eliot Davis, Chronic Hatzalah. I'm bringing in a patient. I need you there now." He said, "I'll meet you in the hospital." And he took care of his care and did what he had to do. Okay. So You know, but you don't always have these. I have plenty of cases, I can tell you, people that had strokes and there was a levaya the next day.
So the reason why technically he was is because he was around other people and they saw.
Yes.
They saw those.
They
symptoms
saw
and-
something, they called, we came fast and we moved. We realized right away what was going on and we moved.
Wow.
Okay? TIA. TIA, you gotta know this.
Thanks in advance.
This is a mini stroke, if you like. Not a very medical way of
It's cute. It's like a
referring
cute
to it, but it's not.
No, it's not.
It's not.
These are all acute.
Okay? A mini stroke. The problem with this is they make us look like fools because you get all the same signs and symptoms as a stroke. All the same. They failed Cincinnati. Boom, you call the hospital, you put in a stroke note, they send down a team, they're waiting for you by the door. All of a sudden the patient's like, hello, I'm good. And you're like, no, you're supposed to be having a stroke.
Have a stroke.
Yeah. Now you want them to have the damn stroke, okay? No, don't make a fool out of me. Okay. So after you explain to the nurses that there's something called a TIA, you finally get to, you know, the neurology team, and they're cool with it. They know. All right? They're okay with it.
Transient ischemic.
Yeah, you need to know what it stands for. TIA, transient ischemic attack. Transient means it moves, right? What's this similar to?
Chemical attack.
No, that's like a blood clot.
Angina pectoris.
Angina pectoris. Agent 47. Yeah, man.
I love that.
Headache. Headache. The reason I mention it here is because there's nothing you can do, nothing I can do. But again, if they do say that they never have headaches and now they're having the worst headache of their life, go back and check for stroke. Okay? That's the first thing about headache.
Is this similar to a cluster headache? Or that's something
No. That a cluster headache is a whole separate situation. Migraines, cluster headaches.
They call them suicide headaches.
The best treatment for cluster headaches is O2. Okay, give them oxygen, non-rebreather mask, really
Yeah,
helps.
he had a tank under his desk.
What is cluster headaches?
They are tremendous headaches. The worst type of headaches, worse than migraines. They just come, people that have them a lot, they know, they need oxygen. They get oxygen, it helps it go away. They become almost paralyzed
They nickname them suicide headaches.
from the headache. Okay? Alright, so not a long slide, just high flow oxygen. This is the most important thing. You read this?
Yeah.
Ellie, read this.
When I get a headache, I take 2 aspirin and keep away from children, just like it says on the line.
Well, it also says that on your restraining order.
Okay, next topic. Next topic. Alright, so this is one of my pet peeves in our organization, and none of my students are going to be as ignorant as some of the EMTs that are out there, okay? So you're going to know the difference. We'll start off with an allergic reaction. Allergic reaction, alright? So there is an allergen, and your body is having an immune response. First of all, you cannot have an immune response to an allergen that you've never had before. Okay? So if this is your first banana, right? Can you be allergic to it?
No.
First time you have it, you cannot. Okay? If this is your first crunchy, can you be allergic to it? No. You have to have another one so that your body sees the first one and says, dude, I don't like that. Okay? Then when you have the second one, the body has already seen this allergen before and can now say, I don't like that.
Could it be like one bite and a second bite?
Possibly, but that would be extremely, you know.
This is
fourth
major
banana?
concept from
Alright.
Hashem that it was made this way.
Can it
It's
be
like
a fourth
Moshe
banana?
Lecavov, you know?
Oh.
Can you randomly
Well, that's the person
Yeah.
that's allergic to eggs.
Don't you can't you
water.
get allergies to your
Oh,
parents
yeah.
like when you're born from the genes?
Tom, let me just finish the slide.
Meaning you can have something once and you'll tolerate it, and then upon the second round, you'll have an allergic reaction to it.
May,
But if you've
yes.
never had it before,
You can,
you can't.
yes.
Yeah, are you able to refresh it so we could theoretically submit questions? It doesn't block this and everything.
Theoretically.
Fran says it's good.
It was.
Not good now.
Now,
I think the mnemonical bonnet
Back.
broke it.
It works.
Exploded
Okay.
It blocked Ellie automatically.
okay. So, allergic reactions, again. These are non-life-threatening allergic reaction. What we see of these things here, we see itching, we see flushed skin, which means red, hives and urticaria. These are a raised red rash, blotches on the body. And you will see a lot of itching, like this. Warm, tingling skin, okay? People can be allergic to many things. Medications, probably the most common. Foods, you know all the different things people are allergic to. Again, an allergic reaction is a non-life-threatening problem.
Can't become life-threatening.
Finish, let him finish.
How do we see an allergic reaction in the field? The person will have hives or urticaria and a red itch on their skin. That's it. That is an allergic reaction. Doesn't matter if it's a small patch like that or if it's the entire arm. It's still an allergic reaction. You all got that? Now,
Don't have it.
these are some things that cause allergic reactions. You can look at this on your own. Redness in the eyes, coughing, edema.
We don't have
I know, diarrhea, vomiting, rash. These are all things.
No, you could
Pulmonary
go to
what's
the, drawing.
Edema, swelling. Now,
Print that
this is the important slide. When an allergic reaction progresses and gets worse, it can turn into something called anaphylaxis. You know this as anaphylactic shock. Okay? So anaphylaxis, anaphylactic shock are exactly the same thing. Now, your allergic reaction has gone from a rash, urticaria, non-life-threatening,
to life threatening.
to
Supernova.
life-threatening anaphylaxis. Now, how do we see the difference? How do we know that we're now dealing with anaphylaxis? So these are the two things. There may be respiratory distress. We'll talk about that. Or cardiovascular problems such as hypotension. Why would there be hypotension? Somebody quickly?
Because
because the blood vessels dilate.
Very good. Very good. Because what type of shock is anaphylactic shock? What type of shock is it? Distributive shock. What happens during distributive shock? Dilation of the blood vessels. No, it's got nothing to do with it.
Dilation is what the
Nothing to do with it. We're talking about cardiovascular problem now. Okay? Cardiovascular. No, that's respiratory.
Vasodilation.
Vasodilation of the arteries. That will cause hypotension. Is this an early or a late sign?
Late.
Late sign. Very
Is there
good.
AMS
So
with
what
this?
you will usually see,
no.
what you will usually see will be respiratory distress. Now,
Is there an early sign?
Yeah, hypertension.
respiratory
But that's
distress.
considered early sign?
What are we going to see? Tell me some things that fit the title of respiratory distress.
Trouble breathing.
Okay, Can we be more specific?
Yeah, to close up your
Labor.
thing.
Wheezing.
Wheezing, I like that one. What else?
Color of his face.
Cyanotic,
Gasping for air.
hypoxic.
Okay, gasping for air,
Hypoxic.
hypoxia.
He's hunched over.
AMS.
Hunched over.
AMS has nothing to do with the respiratory distress.
Using his muscles to breathe.
Okay, accessory muscle use, I like that.
Going like this,
Tripod position.
going like this.
Tripod position,
Excessive muscle use.
Sorry, what's the
No, what's that called when you?
that's Levine sign.
Yes.
That's for a heart
That's a
attack.
heart attack.
What's
Perch lip
excessive
beats up
muscle
with-
use?
No,
Pursed lips,
the
Blue skin,
leaning
poor
against
circulation.
okay, cyanosis. So these are a few things that are connected to respiratory distress, right?
Carbon dioxide in the blood.
No.
He's Googling.
So, what about swelling of the tongue?
You tell us.
No.
That wouldn't cause respiratory distress?
Oh, that
well, it would. If
Better
it blocks
believe it
blocks
would.
Well, why is it gonna?
Better believe it
But why
would.
is he having swelling of the tongue?
Because of the anaphylaxis causes this.
But it's
Edema, remember we had over here?
But why?
Edema, right?
edema.
But why?
What's the
His
deal?
blood
The
vessels-
Swelling,
The tongue
swelling,
swells?
fluid going into places where it doesn't
Well, it just
usually
said
go.
edema, it didn't say where.
Okay, so anything in the mouth, edema of the larynx, laryngeoedema, swelling over here in the neck,
Lips blow up also.
okay? All these things are considered part of
Respiratory.
respiratory distress. These are early signs. This you will see very early on in an anaphylactic reaction. If you see respiratory distress, or if you're delayed and you see hypotension, you should treat. How do we treat?
EpiPen.
EpiPen.
EpiPens, right? Now EMTs are now allowed to actually draw up epi in New York State, New York City. We did training on that for some of the Hatzalah neighborhoods. You're actually allowed to draw up a medication just like a medic does.
And
Because
give it
these
a-
were costing about $1,000 each, and a vial of epi is about a quarter.
It just
So-
shows what really is behind everything.
Yeah. Okay?
Either use that or
Screlly, that's why he's going to jail.
And you put a shot in, right?
Huh?
So how do you use it?
What you want him?
How do you use it? Guys, come on, we did
The
this.
lateral leg.
Very good. Lateral thigh.
Right.
Second.
10 seconds.
There's nothing you can do to maintain an airway if someone has an edema in the mouth, right?
When you do that.
Yeah, give them epi. Why? Why is epi? What does it do?
It's a
It's a
vasoconstrictor.
It's a vicious.
That's not going to help the breathing.
It reverses it.
It's a bronchodilator.
No.
Very good.
Adrenaline. Oh yeah. Well,
Very good. You need to know both. It's a bronchodilator that will help the breathing, and it's a vasoconstrictor.
Oh, so what's happening?
Right there.
See, I switched off the page so you wouldn't be able to just read it, right? I guess he read it before I turned it up. It makes, you know, he wants you to think he knew it.
I came to Shravi's brother's house.
Yeah.
4 o'clock. His brother pulls out lights and sirens. Came back an hour later, and he said a child, 8, 9 months old, had an allergic reaction, what appears to be. But he said that Hatzal, they don't have the EpiPen anymore. He had to do it.
Draw it up.
He had to draw it himself, stuck it straight in the leg, and he went off to the hospital.
Okay, you're supposed to do it in the arm now.
Or maybe he did in the arm, I don't know.
Good.
No, I didn't.
EpiPen goes lateral thigh, okay, like she's demonstrating.
wow.
But
Okay.
Hopefully it's not a real one like we
The new one
had.
goes in the arm.
Now I hope that is a real one.
Well,
The new one goes in the arm.
But he says it takes him longer, not crazy,
You gotta put it together.
because he has to draw it out.
Because he's not used to it, because EMTs are not used
Yeah,
to.
Amateur. He's an
It's
amateur.
chick shock for you.
Alright, I never had an EpiPen, so I don't
It's
know.
chick shock for you to do these things.
And the vial,
Yeah.
it says 0.15 and 0.3, like
Yeah.
you have to be an idiot to make a mistake like that.
Yeah, but we're dealing with EMTs, so.
oh, this is the first time.
I'm on the question board right now.
Oh, you let it,
brought
you
that
let
on
it.
yourself.
Good. There are two we saw before when we did pharmacology. EpiPens come in pediatric and adult. Okay, the dose, as Ellie correctly said, 0.3 milligrams is the dose for an adult or 9 years old and over. 0.15, which for those of you not so good at math is half, is for 9 years old, less than 9, 8 and under. Okay?
They switched it. They switched it.
To what?
It's above 50 pounds now.
Okay.
I know, because that's what they just told my wife.
Okay.
She's on expand?
No, it's done.
Oh, so
Alright.
your son is out.
Here's how you use it again. You take off the safety, hold it into the lateral thigh, keep it there for how long?
10 seconds, no?
10 seconds. Want to pause?
Movie?
So, poisoning and toxins. We'll do this quickly. There are different methods of poisoning. Definition. Poison is any substance that is harmful to the body. Toxin. This is a man-made poison. You will not be tested on that. There are different ways of getting the poisons into the body. They could be inhaled, such as carbon monoxide, right? We've spoken about that in the past. That is an inhaled poison. Absorbed, we'll sludge them. We'll do this on another day. Injected, such as animal bites, bee stings, or why do I have here? Injected could be through medication, injections, or insects. And ingested are things that people drank that they shouldn't have done. All these are common poisons. Now,
What's S&S?
signs and symptoms. So inhaled, we know about carbon monoxide. Basically, for poisons, I have this blocked, which really shouldn't be blocked. I would prefer if it wasn't, because that is the most important thing
What?
on this screen.
Test question?
What?
Where's the mouse?
Agent 47.
Here you go.
Test question.
So this really shouldn't be blocked. Oh no. Guess I can't edit now. Alright, so basically it says here, call online medical control. Write it in if you don't have it. That is the rule for syrup of ipecac and activated charcoal. I think I will remove all the dosages from the slides because you do not need to know them. You do not need to remember them.
What's syrup of
Okay? We spoke about the medications in the other night. Okay?
They don't use it in New York City.
These are some of the signs and symptoms that you may see from carbon monoxide poisoning. We've spoken about this also in the past. They may be vomiting. They may be dizzy. They may lose consciousness. All sorts of big problems. But again, ingested syrup of ipecac or activated charcoal. The answer always is
Call online.
call OLMC. These are some questions, some important information medical control may want to know. What did they take? What type of substance was it? When did they take it? Meaning, you're there now. We understand that. But did they take it an hour ago and then they called you now? We need to know that. How much did they take? Okay, now you need to fathom this out before you call. So, the way we do it is, let's say with pills, every bottle has a date when it was filled. You calculate, there were 30 pills in the bottle. They're supposed to take one pill, for example, every day. That's a month's supply. Today is the 10th of the month. Therefore, there should be how many pills? 20 pills in the bottle. Now we count the pills. And there's only 4 or 2 pills, right? So little Bobby there has eaten a lot of pills, okay? When does this happen, by the way? This happens when grandparents come to stay. Because when grandparents are in their own little home or apartment, their medications are safe. There's no one touching them. They can leave them on the kitchen counter. They don't have to have childproof, right? But grandma and grandpa come to stay, right, with a son or son-in-law, daughter, whatever it is. Now they put their pharmacy on the nightstand in the room, okay? And little Bobby, he's coming in and out, right? Because he wants to come see grandpa, right? But when grandpa ain't there, he walks in and he sees all these little candy bottles, right? So now little Bobby has taken, 14 blood pressure pills, okay? That's why little Bobby is now unresponsive, laying on the floor.
That's a lot of Viagra.
Okay, or whatever else grandma, grandpa is on, okay? I'm just giving you one example. How much? Try to figure it out, okay? Duration of contact, if it was transdermal, if it went through the skin, how long was the patient in contact with it? Weight and age of the patient. So these are things, again, now you'll be tested on, but you need to know this stuff. All right, some words that you're going to need.
What?
I like this word, synergism. Synergism. This is how two drugs combine and work together. Two drugs combining and work together. That's a good word.
Yeah.
Okay?
Synergism.
Withdrawal. You need to know this word. Withdrawal will be a set of signs and symptoms that is typical to a person having stopped using a various drug. Give you the simplest example. If you drink a lot of coffee, and then you get a fast day, and you get a headache the size of Texas, that is withdrawal. Yeah.
You have synergism from an individual drug.
You don't.
Combine the fact-
Then it would be called pharmacodynamics.
individual drug.
I don't know what that's.
Inuism.
It means greater than.
Yeah. Greater than one drug. So you'll have an effect that combines.
Different drugs or two.
Right, so I'll give you an example. Viagra and nitro.
Oh.
When you have both in the system, you're going to have a real drop in blood pressure.
Because they're two different drugs, but they're doing
Doing similar things.
Gotcha.
Okay? All right. These are the ones I want to talk about. Withdrawal and synergism, the other ones don't worry about. Okay. Abused substances. Here we go.
Yeah.
All right?
You brought samples, right?
No. You were supposed
Yeah,
to
the
bring
banana. The only thing on the table is a banana.
No, the banana's not really an abused substance. If it was,
Depends how you use it.
Brian, go right ahead. Let us know. Do tell. All right, so here we go. Alcohol and narcotics. Again, these are a few of my favorite things, right? To quote, what's her name? All right, alcohol. Not that any of us have any idea or know anything about this, but this is what I've been told.
We think we know, but when you're in the room, we don't know anything.
This is what I've been told. It is a CNS depressant. CNS, Central Nervous System depressant. This means that we probably shouldn't be driving. We shouldn't be going on calls. We shouldn't be responding, right?
There's no myth out here that a guy backed into Brock's on the bus. He backed into Brock's parking lot. They opened the door of the bus, pulled the patient out, and they're in the middle of a supermarket parking lot. The guy was drunk.
Instead of the hospital.
Okay, slurred speech. All right, some of you.
The guys in the back didn't.
Some of you may be familiar with some of these reactions: slurred speech, slow reactions, mood alteration, nausea, vomiting. Let's just clarify the difference between nausea and vomiting. Nausea, the feeling that you want to vomit, but have not yet vomited. Nausea, the feeling that you need to vomit or want to vomit, but have not yet. Once you vomit, you are not nauseous. Now you have vomited. In medicine, we write N/V if there was both, meaning there was nausea, and now it's all over my ambulance floor. That would be N/V, nausea, vomiting. Okay? Poor motor coordination, therefore drinking
And driving.
is not. No, driving is not. You see?
Ali, what's in your?
No, I do. I know. There is. Slur speech. Right. Okay. So I gotta behave myself. Poor motor coordination. Diffusion. That means I can walk through walls, right? When I've had enough to drink. And DTs. Now I want to get to DTs.
What is DT?
Okay. Yes. I'm gonna explain. I'm gonna explain you.
What did you say?
I'm gonna explain you. Okay, good. DTs. Something you'll be tested on. DT stands for delirium tremors. Okay, don't ask me. That's what it's called, delirium tremors. This is the withdrawal symptom that you will see when a drunk who drinks copious amounts of alcohol decides to go cold turkey, not wild turkey, cold turkey, and stop. Okay, and they stop. I don't know if you remember a famous resident of our neighborhood by the name of Zalman. Zalman the Shikker, right? We used to have him with these DTs. Every so often he'd stop drinking for a couple days, and he'd have DTs, delirium tremors. It looks like a seizure almost. They shake, but they're conscious. That's the difference. That's how you know it's not a
really
seizure.
Keep a bottle in the ambulance to.
Yes, you need to keep a bottle ready for.
He always has an emergency.
He had in his pocket.
What's DT?
Delirium tremors.
Is that a drug EMTs are allowed to assist?
You're laughing, but there is a treatment in hospital that sometimes you need to give alcohol to a patient not to know.
Medication's
It's similar to methadone. Similar to methadone?
Yeah, well, that's that idea, yeah. So,
Are we gonna learn Narcan now? Oh, we did it already.
no, guys, you need to know delirium tremors, you need to know this is withdrawal from alcohol. That's why it's under the alcohol.
Oh, godless.
Okay? Good. And this is the, not quite sure why there's that symbol on the beer, because
And it looks like a
Pirate
light
beer.
beer. It looks like a Coors Light. Look at it.
It's a pirate.
Yeah, what is the? I think that's an emoji smile.
Toxic.
all right, moving on to narcotics. Remember, we're not cops. Narcotics only mean what?
Fun.
Opiate derivative.
Opiate derivatives. Very good. Shrekky, you really?
He can read.
Yeah?
And you put it on the board.
Oh,
Crazy.
I know.
Shaggy is so proud.
Narcotics are opiate derivatives. Can we get some examples, please? Not the ones on the board.
Heroin,
Crack.
Oxycodone.
marijuana,
No, not crack, not marijuana, no. Vicodin, I'll give you that one.
Morphine?
Oxycodone, morphine,
Valium,
Morphine down
No.
the board.
Percocet.
Oh, shoot.
Percocet.
Percocet,
Good stuff.
Xanax?
Chopped up.
No.
Xanax.
Xanax.
Yeah, maybe has
What was the
some.
other one?
Molly.
Ambien.
No, not Molly, not Ambien, not ecstasy.
Shrooms?
No, none of those. Okay,
What else is there?
PCP.
Purple haze.
no,
Acid?
no.
I'm sorry, my narcotics.
Okay, there's drugs called, there's Dilaudid,
Sour diesel.
okay? There is, somebody mentioned it earlier.
Molly.
No,
No.
what do they put people on when they?
MDMA.
Morphine.
No,
Narcan.
no, what do they put heroin addicts on to wean them off? Methadone, thank you. Another one is fentanyl.
I said that like 5
Okay,
times.
okay, good. So we've got some of the main ones covered. They're used for analgesia. They're used to relieve
Do we have to
pain.
know all those drugs?
No.
No.
What's analgesic?
Here are the signs and symptoms.
pain.
Relieve pain.
That's what they're made for.
Yes, that's what they're made for. They're all legal except for heroin.
Believe it or not.
All opiates are legal. All opiates are used. I use opiates every day, almost.
On yourself.
No,
When you get up.
Okay? All they're the best pain relievers. Okay?
Highly addictive.
Highly addictive.
Block
But
pain receptors.
Yeah. So what are some of the signs and symptoms? Decreased respiratory drive. This is the one we look for, and this is the one that we will give the Narcan for. If
What do
it,
you mean respiratory drive?
the ability to breathe, the desire to breathe.
They don't want to. Body doesn't want to.
Okay, they stop breathing. Respiratory arrest, respiratory failure, respiratory distress, dead. Respiratory arrest, dead. Get a Narcan.
But when you say the respiratory drive, is that the body doesn't want it?
The brain, yeah.
The brain.
The brain.
It's not that the lungs can't do it, it's that the brain
Brain doesn't send the messages. Okay? Pinpoint pupils, remember this?
Yeah.
Right? Only narcotics, only opiates. Guys, you will be tested on all this. Okay? Know this. Stimulants such as uppers, cocaine, coffee, what's it called? No doze, no snooze. Right, we're moving.
Sugar.
A lot of good questions.
Good, we'll get to that soon.
Acid.
So these things are uppers, crack, cocaine, all this stuff. This speeds everything up. Okay? These work on the sympathetic nervous system. These just make everybody go faster. You do not want these people in the back of your ambulance if you can help it. Okay? These people are usually unresponsive. Okay, the good ones.
Like drunk ones, something.
Okay, the drunk ones can be a problem, yes, but usually they're unresponsive
What is it
also.
that when some people are drunk, they're the wild
Yeah.
and sometimes they're relaxed?
It goes from one usually to the other. It starts off, they get wild, they get hyper, and then it calms them down. These people don't calm down. These people, you should probably get PD to help you because they, they'll break your head up.
Which one's that?
The uppers, the
What's the diet?
stimulants.
Why diet pills?
Oh, they have
Your digestive system.
same thing.
Same thing.
What happens if someone takes
Hey, I like the bottom of the slide.
Yeah, stimulants. See that?
Did you make this slide? Yes, you made this. You made this slide? Wow, very nice.
Okay? So more alertness, energy, attention, heart rate, blood pressure, respiratory. Everything goes up, everything gets faster. Barbiturates, downers. These are, again, CNS depressants. Okay? Valium. Used to see more of this on the streets.
Why do you
It's
want
not
that?
so popular anymore. There are much better things people like to take. I'll show you in a minute. So this you don't really need to
Why
know
do
too
people
much
want to
about.
take the
What is the other
downers?
ones before the value?
Stimulants, uppers.
No, those two.
That does all this.
No, what are
Don't worry about it. All
Slows
same
down
type
your
of drug.
your central
Now,
nervous system.
This
Don't
is
stare at that picture.
yeah, stare at the
Give you a
picture.
headache.
That is your brain on LSD. Okay,
Is LSD good or bad?
you want your brain to do that?
This is what they told me.
LSD, shrooms, okay, Molly, MD, what's it called? MDMA, all these are hallucinogens. These are the ones that are seeing the pink elephants floating around the room. These people can be quite funny to deal with and to treat. Okay, the Molly ones are always sucking lollipops. That's how you know that they're doing Molly.
What is Molly?
It's a drug.
I work with the
Molly
guy.
on the
I work
Wally.
with the guy. I mean, I don't work with him in the company, but he's like a partner in another company, and he's always sucking lollipops. And he looks like legit. Like
Well, that could also just be weed.
Why are they sucking
He
lollipops?
could just have like
I think it was
oral-
just-
Oh, because they feel like they're gonna get dry in the mouth, so they
He wasn't
suck on
listening as a
lollipops.
child.
They also like hugging people a lot.
Yeah.
They don't like wearing
They're
clothes.
very warm.
No,
as
he likes
they
women.
diaphoretic.
Yeah,
Likes women.
He doesn't
right. Do they
wearing
like
clothes.
hugging them?
Doesn't like wearing clothing. Goes to Miami all the time.
There you go. So that's what he's on,
Like
Molly.
everybody in Flatbush.
I'm gonna let him know. Thanks.
Let him know. So these things, again, you won't be tested on this too much, but this is LSD and that sort of hallucinogens. This one is obviously everybody's favorite, marijuana, also known as ganj, pot, grass, whatever you want to call it. There's a million.
Legal
What
in
does hashish
California.
fall into?
This,
Hashish
is this.
this. It's all the same stuff. These people, I've never had a call for somebody on marijuana. Never.
Really? There are plenty of people who are on your bus as a side effect, but they weren't.
Yeah, but no one's calling for
Why,
somebody.
people have like, you know, a little too much
Lack of
brownies,
marijuana?
Yeah, oh yeah, I had that. But typically, you don't get that.
You don't remember that
Unless
call?
it's late.
I have a
Lack of
question, asking for
marijuana,
a
lack
friend.
of marijuana.
Why do your eyes
They
get
didn't have
red from marijuana? No, for real, why do they get red?
Dries them out.
So they turn red?
Can do.
When you're tired,
And then you have these little
They get
bottles
the
that make your-
munchies, right? They get hungry,
Munchies for punchies.
right? Constantly need something to eat.
Why do you think Ali brought in crunchies tonight?
There you go.
Must have come down.
Alright, so that's that. Care for substance abuse, ABCs. ABCs, okay? Typically, the only thing you can actually treat is opiate overdose, and only treat it if they stop breathing or they have respiratory distress. Otherwise, just go to the hospital. You don't want to wake these patients up. I hope you understand this.
You know what?
Don't wake up.
Don't kill their eye.
Yeah, don't kill the high. Don't wake up the opiate patients just because the state lets you give 4 milligrams,
But
okay?
aside from the opioids, let's say the crack or any of those.
Nothing you can do.
Well,
ABCs.
ABC, just
Go to the hospital.
and get them breathing.
That's
Do
it.
they stop breathing as a result of the
Of crack cocaine,
overdosing?
the worst thing that happens to crack cocaine patients is a cocaine-induced MI. Sometimes the heart goes so fast, they can like make themselves have an MI.
They also
It's
don't
rare.
have a lot of teeth.
They have a lot of
They
teeth.
don't have a lot of teeth.
Okay.
Unnecessary.
From the snorting?
Yeah.
Why?
Their nose, they don't have,
Yeah, septum can get blown out.
Septum, but their teeth are fine.
Alright, let me do a few more important things. Guys, concentrate. Don't think of intoxicated patients as just being drunk. Remember, a drunk can sometimes, you can think they're drunk and really they're hypoglycemic. There are similarities to the behavior sometimes, okay? Always check medical things, always see. Just because they look intoxicated, they may be hypoglycemic. The alcohol itself may have dropped them, into a hypoglycemic state. I once had I don't want to talk about it now, but I once had a whole fight with an EMS boss who said that this patient was drunk, and I said, no, she's not, she's hypoglycemic. And we had a massive fight, and whatever. I don't want to get into it now, but obviously I was right.
Can't you sell that?
Syncope.
Blood test.
Syncope.
Glucometer now.
Yeah.
Guys, you didn't know this word earlier, make sure you know it now.
Syncope.
Fainting, okay? Also known as psychogenic shock, or we say the patient had a syncopal episode, okay? No matter what, syncope. This is the word you need to know. This is what we call it. Ephraim, could you read, please?
There may be other ways to learn it. It's not as good as this one.
It's true. It's true. It's endless.
That's it?
Can you refresh the slide?
Look at me,
Answer the
dude.
Well,
question.
let me have some